Wonderful. Thank you, Simpiwe. So I think with that, let's start. And maybe just from my side, a warm welcome to everyone to the school's noon meeting. And today is our turn from family medicine and interdisciplinary palliative care and medicine. We're really grateful to have Dr. Lindsay Farrant here, who's going to present on what are the palliative care needs of patients with COPD in primary health care. And these are the findings from the ACID phase 1 project. And I don't know, Lindsay, you're probably going to speak to also about how that is linking with your own doctoral research work. So maybe also just to say that Lindsay is wearing many hats at the moment in our division, and we're really grateful to have you take on all those responsibilities. You started off as just being a research officer with the ACID project, working closely with Liz and Renee. But since then, you have evolved also as a teacher and course convener for the research methods course in our which is a good example of collaboration between family medicine and IPCM. And so you're already getting involved with not only growing as a researcher, but helping to share the skills of how to grow as a researcher with others. So you in a way, it's very much Ubuntu. You're learning and you're giving. so Lindsay, yeah, and please go ahead. We look forward to hear your talk, and people are welcome to use the chat function to also pop in questions as we go along. Yeah, so over to you, Lindsay. Thank you very much.
Sure, thank you, Klaus, for that. And yeah, I'm going to share my screen, and I think I'm just going to turn off my camera. So just while I find my presentation. Okay, I've shared now, so if you can just tell me that you see. Good.
If you can just put it in maybe in slideshow mode.
Yeah, thank you.
Perfect. Thank you so much.
Sure. Okay, so I'm presenting today and really pleased to be presenting. So really the findings from ACID phase 1, and I've entitled it, What are the palliative care needs of patients with COPD who have care in primary health care? And our team is represented here, and Liz was the PI for this study, and or is, and Joy, Olona, and Zoe were the research assistants conducting the data collection. Kennedy and Richard are based in London at King's College and are integral to the whole project. And so we are a part of what is called ACID, Health System Strengthening in Sub-Saharan Africa, funded by the NIHR and UK Aid. And there are various other projects in this collaboration, some in South Africa, a number in Ethiopia, some in Zimbabwe and in Sierra Leone. So it's an interesting group of researchers looking at primary health care and the needs there. But we are doing the only palliative care research on that team. So it's really diverse and interesting group to work with. So what is the background? We know that in non-communicable diseases really contribute significantly to the mortality globally, and that a large proportion of these deaths are in low and middle income countries relating to various reasons. And we know that COPD is currently the 4th leading cause of death globally, but is predicted to move up that ladder. So when considering palliative care and pain relief, the Lancet Commission found that 45% of people who died globally experienced serious health-related suffering leading up to their death. And of these, the vast majority are in low and middle income countries. And it's here where access to pain relief and palliative care is limited and often very limited. So what does policy say? What can we glean from this? So we know that the Global Initiative of Chronic Obstructive Lung Disease has recently recognized the inclusion of palliative care as an approach alongside standard care for all stages of COPD, not just the advanced COPD. So that relates to symptoms, quality of life, and so on. And we also know that the Declaration of Astana includes palliative care as integral to the provision of holistic primary health care. And we have the National Policy Framework and Strategy on Palliative Care. So we have policy in place speaking to this. And when we look at how do we measure this? How do we compare outcomes? Patient-reported outcomes are really a key factor in this. Looking at what is the evidence for palliative care for COPD patients, there is a fair amount of evidence. A lot of it comes from high-income countries. And a number of reviews have shown that patients and caregivers see that palliative care is appropriate for their care to address their symptoms and concerns. And a specific study done in the UK had recruited patients with any cause of breathlessness, and COPD patients comprised 54% of that sample, and they provided a point of care, time-limited point of care of integrating palliative care alongside their usual care. And what they showed that in the intervention arm, palliative care reduced breathlessness for these patients, reduced hospitalizations, and often how they did that is through self-management. And the care also improved quality of life, decreased distress, improved satisfaction with care, and improved dignity and even survival. So our project, the overall aim, is to develop a feasible and acceptable primary care-led integrated palliative care intervention for patients and families living with COPD. But we needed to know what the evidence was in South Africa in our setting. So these are the objectives of ASSET Phase 1, and I'm talking today mainly about objectives 4 and 5, but I'll touch on objective 3. And objective 4 talks about measuring the prevalence of symptoms and concerns among these patients, and then objective 5, the qualitative component describing stakeholder views. So just to talk through the inclusion criteria, for patients, it was any adult patient with a diagnosis of COPD of any stage. They just needed to be able to communicate in one of these 3 languages and obviously be able to give informed consent. The same for caregivers, and we use the definition of the unpaid informal caregiver. For healthcare practitioners, it was any healthcare practitioner involved in seeing COPD patients in primary care. And this tended to be doctors, nurses, physiotherapists, and some pharmacists. The only exclusion for patients was that they needed to attend primary care. So housebound patients were not included. So essentially, it's a cross-sectional mixed method study, and we had 8 primary healthcare sites. I'm going to briefly touch on the survey that we did with facility managers, and then mainly talk through these the survey of patients, and then also the qualitative in-depth interviews. So this, I debated whether to include this, but I thought it's useful, and we know this, but it sets the scene, talks to the context, and we asked the managers what they thought were the challenges relating to COPD care. And so they talked about the issue of diagnosis, being able to differentiate between COPD and asthma, for instance, not really having a palliative care framework, and home care being a concern, home oxygen always challenging, and then access to medication is sometimes complicated. They talked about the underuse of quantitative measures such as spirometry and the challenge of access for lung functions, the limited access to pulmonary rehabilitation and smoking cessation programs. And then also talked about patient factors, patients not attending regularly, and clinicians not necessarily always following the evidence-based guidelines. Right, so now I'm going to move on to the survey. So generally speaking, unless I say so, the numbers, the total number of participants is referred to in all the statistics. So we recruited 387 participants, were included in the data analysis, and just over half of the sample were female. The mean age of just under 60 years of age, and the predominant language being Afrikaans. 44% of participants said they were still smoking, but we note that we have some missing data there. And patients reported, from their point of view, the number of years since they had been diagnosed, and that was not from the file. So that was just over 8 years since diagnosis. So, and they're now looking at the COPD gold staging. So this is quite an interesting and important finding. Majority of patients did not have a gold staging in their file, and these were patients identified with COPD in their file and by their clinician. So this is interesting. When we looked at management, most patients said they had not missed medication in the previous week, and when we looked at number of hospitalizations, at least 50% of the participants had had a hospitalization in the preceding 12 months. Here's another interesting piece of information, and we've seen that we know that referral to respiratory medicine is challenging, but about just under 20% of participants had been referred to a respiratory clinic in the previous 12 months, so a specialist clinic. Very few patients had been referred to physiotherapy, interestingly, very few to counseling, and some, 16%, to a social worker. Okay, so moving on to look at the functional status of patients, we used the Karnofsky Performance Scale, and the mean KPS was 72 with a median of 80. So I've included here just to show you the description. So a KPS of 80 is a patient who has normal activity, but with effort and some signs and symptoms of disease. And a KPS of 70 is a patient who can care for themselves, but is not able to carry on normal work or normal activity. So it does show us the vulnerability in terms of function of these patients. Right, okay, so this is now looking at the activities of daily living, and we use the London Chest Activity of Daily Living Scale, which really is designed to determine what the level of dyspnea is while engaging in the activities of daily living. Lower scores are better outcomes, so the mean score doesn't look, it looks in the lower half at least of the potential score, but if you break this down, the effect that the shortness of breath has on the patient's activity of daily living is, for majority of the participants, 68%, a lot. So a large effect on the ADLs. This next test is an interesting one. It's a COPD test score, the CAT score. It's actually accessible by patients online, and rates the patient's current assessment, self-assessment, and looks at the impact of their COPD on their daily lives and their well-being, and asks questions about cough, mucus production, chest tightness, walking uphill, the limitation on ADLs, their confidence in leaving home, the effect on sleep, and on their energy levels, all on a scale between 1 and 5. And so the mean score for this group was 26, so putting it in the high impact level range. And so I've just put here what this means, and what the scale describes for a score of over 20 is that COPD stops them doing most things that they want to do, and that they're afraid and may not feel in control of their chest problem, and then makes various suggestions for possible management considerations. We also looked at the social support the patients have. So from a demographic point of view, majority of the patients did not live alone, and most lived in a formal house with sanitation inside. And then we used what is called the Medical Outcome Study Social Support Survey to assess, not in terms of resources that patients have access to, but in terms of more sort of human resources, the human support that they may have access to. And the mean score is 73, which with a higher score meaning a better outcome. So this is interesting. And all sub-scores, the tangible support mean, the emotional support, affectionate support, and positive social interaction means are in the higher scores, meaning better outcomes. And I think this is interesting, and it's possibly something we could tap into in terms of the support. If we could support families better, perhaps that would be a good angle to look at for care. Okay, so now another important tool, the CESD, which is a 20-item scale with screening for depression with a 7-day period prevalence. We broke it down into these 3 categories, which is recommended for the patient population in Africa, and 55% had no evidence of depression, but 20% were seen to be at risk for mild depression, with 23% at risk for major depression, highlighting again the importance of caring for the patient's mental health. Okay, moving on to quality of life measures. So we used the Africa Integrated Palliative Outcome Scale, the IPOS, with the 3-day period prevalence. And the items here indicate there are 3 items for caregivers, but I've not displayed them here. So these are all items for the patient to respond to. And we can see that the scores 4 and 5, 4 out of 5 and 5 out of 5 are the most burdensome for the patient. And for breathlessness, 22% of the participants described their breathlessness as overwhelming, 28% describing it, giving it a score of 4 out of 5. So showing the burden of their breathlessness. And then looking at the ability to share feelings. So the question is, have you been able to share your feelings with your family and friends in the last 3 days? With 24% of participants saying they have not been able to share at all. And then another really key result here is that when patients were asked, have they received enough help and advice to plan for the future, 40% described having no help at all. Just describing this more clearly in this slide. So 40% rating that they had no help or advice to plan for the future. If one looks at the 4 out of 5 and the 5 out of 5 together, half of the participants felt that they had not received enough help or advice to plan. So to complete the picture on symptom prevalence and symptom burden, we used the MSAS, Memorial Symptom Assessment Scale short form, which gives a 7-day period prevalence, and the 10 most prevalent symptoms were found to be shortness of breath, unsurprisingly, but with a prevalence of 90%, pain being the second most prevalent symptom, with a prevalence of just under 80%, cough 77%, and worry being one of the psychological symptoms at 65%, and feeling sad just under 60%. So look at that a little bit in more detail. So looking just at the burden from physical symptoms, the Memorial Symptom Assessment Scale looks at 28 physical symptoms and 4 psychological symptoms. So for the physical symptoms, shortness of breath was very much burdensome for just under 50% of the population, correlating with the IPOS. And the other one that I've highlighted in yellow which was the most burdensome symptom of all, according to the MSAS, is the patient's difficulty with sleeping. over 50% saying that the difficulty in sleeping is very much burdensome in their life. So again, an issue to address from a symptom point of view. Then looking at psychological symptoms. The 4 symptoms assessed for are worrying, feeling sad, feeling irritable, and feeling nervous, with significant burden for all of them. But if you look at worrying and feeling sad, around 2/3 of participants described feeling worried or feeling sad frequently or almost constantly, speaking again to that the CSD findings and the concern, the mental health aspect of the disease. Right, so I'm moving on now, changing gears into looking at our qualitative interviews. And the objective was to describe stakeholder views and their views on symptoms, concerns, management, and potential training needs. Again, cross-sectional, we used purposive sampling. Orlona and Joy, between them, conducted 63 interviews, and we had 22 patient interviews, 19 caregiver interviews, and 22 health professional interviews. And the analysis was by a thematic analysis. We analyzed all participants together. We didn't group them by patient, caregiver, and professional. We started off with initial inductive analysis, where 4 of us looked at 8 transcripts and identified emerging themes and sub-themes. We then developed a coding framework and then analyzed according to that framework. And as coding was completed, that was adjusted as it was needed, as themes, additional themes or sub-themes emerged. So this is not necessarily very easy to view. I'm sorry, I couldn't get the sub-themes clearer, but this represents the themes and sub-themes. So the first theme is communication, the second one being the experience of the patient and the caregiver, the third one the experience of an interaction at the health facility, and then the fourth theme being patient preferences and patient agency. So just breaking it down a little bit more, communication we broke down into sub-themes of patient healthcare practitioner communication, family healthcare practitioner communication, information sharing, education, and self-management. For the experience of the patient, we had a sub-theme of function, financial impact, transport issues, risk factors for disease, and then physical symptom burden, psychosocial and spiritual symptom burden, stigma, and coping strategies. For the experience of the healthcare, we talked about systems, emergency, OPD, hospital, teamwork, medication, transport, and then discharge planning. And there was a small sub-theme of end-of-life care. And then for patient preferences, this was the access to care, the transport, the need for listening to the patient, and then potential interventions. Right, so I'm not going to give examples of all themes, but I'm going to give some examples of quotes and findings for some of these themes and sub-themes. So here, looking at the healthcare practitioner-patient interaction and communication, the majority of participants felt that or maybe not the majority, but a number of participants felt that their relationship was satisfactory and the communication was good. Some participants felt that there was need for a different communication, and that there was very little communication in many cases. One patient, the last one on the slide, described the benefits of a doctor who took time and effort to communicate with him, and then that doctor moving on and not having similar care from other healthcare practitioners. In terms of information sharing, patients described varying degrees of detail of information that they had received, Healthcare practitioners reported educating, but also spoke to the issue of the differentiation of asthma from COPD in a diagnostic context, but also specifically in terms of patient education and helping patients understand the difference. One professional said that patients tend not to know what COPD is. And another caregiver spoke to the fact that at the hospital she tended to get the long version, and at the clinic they tended to get the shorter version, and she really wanted the long version. Or it might have been so in terms of continuity of care and in communication, patients and caregivers described how constantly seeing a new doctor was challenging, and then having to repeat oneself from scratch, getting annoying for one caregiver, but also making one patient feel sad, and folders going missing, adding to that problem. In terms of education, there was definitely from patients and family members and professionals the idea that smoking cessation was necessary, and patients wanting help and finding it very hard to quit smoking. In terms of inhaler technique, professionals knowing clearly that the technique for inhalers is really important, and aiming for that education, but realizing that it might always be it is a challenge. In terms of self-management, this professional talked about the distress that patients have when they are acutely short of breath, and that all they really want is relief. So they want to use their salbutamol, and if that doesn't work, they will do whatever they can, and sometimes that's coming to the hospital. But that because they don't see an immediate relief from a steroid pump, they're not really sure about that, and not necessarily using it effectively. Patients did talk about finding prednisone whenever they could. One caregiver spoke about a fan not necessarily being helpful. Another patient talked about traditional remedies not necessarily having helped, but what had helped was giving this particular patient a breathing exercise. Just some comments from patients about function. Function in terms of work, not being able to work, and the impact socially, just not being able to engage in, for this patient, dancing, and therefore being more and more isolated at home. And then functionally in terms of being able to get around at home, not being able to climb the stairs like you used to. From a financial point of view, clearly a lot of impact. One patient described the impact of having to get to hospital regularly. He had comorbid lung cancer, and the suffering resulting from this expense. And professionals absolutely realizing that this plays a big part. Just briefly, getting ambulances to go to the emergency unit a challenge for many patients and participants. Again, looking at physical symptom burden, exercise-induced dyspnea creating a challenge for patients. One patient describing, I stopped smoking, but when I actually walk in the house or do something, I have to stop because I feel like I'm someone that's run a mile. And then the effect of anxiety relating to the shortness of breath. And this patient describing really clearly, your shoulders, it's up there and it's like that. You just cannot relax. And then again, the issue of sleep. I just don't sleep at night for another patient. Psychosocially, a lot of impact from an emotional point of view, worry, fear, sadness, One patient describing regret and loss, realizing the impact of lifestyle on his current health, or her current health. And then the fear in acute breathlessness and anxiety, and the professionals recognizing that anxiety, and just recognizing they need a way of finding relief. I've spoken a bit about this, but living conditions and the stress that people live under, patients and families dealing with these things in different ways. Stigma was an interesting one. Patients feeling, or professionals feeling, it's not always easy to care for somebody who's been a smoker all their life. And patients, also one patient describing the effect on her employment, where the coughing she was experiencing was thought to be an infection, and so it affected her employment. So the healthcare facility experience was varied, and for same people expressing gratitude, but also frustration. So relief that they didn't have to pay for medications, but at the same time, a struggle to be seen in an acute illness, causing frustration. In terms of resources, a lot of patients and caregivers talked about the desire for nebulization at home and oxygen at home. And one caregiver saying now that they have a nebulizer, they don't have to rush to hospital as often as they did before. The professionals talking about the need for spaces, that we used to have them, but they seem to be not so easy access, although I've heard during COVID that was improved. And time, a big resource that is a challenge for everybody, patients, family members, and obviously professionals. Another issue that was raised, not by only this participant, but by others, was the issue of privacy in the consultation. And this participant talking very clearly about the fact that because she was being consulted in an open room with other people sitting there, everybody can hear your complaints. So I just say nothing. And clearly this impacts the care she receives, or he receives. Professionals described the lack of policy focus on COPD, and also the implications of this, that this professional saying COPD is currently sort of like the stepchild of the illnesses at the moment, and it'd be nice to focus some attention, and talking about the return on investment as probably being worthwhile. And in terms of training needs, patients and caregivers talked about communication and a desire for attention in communication, and professionals talked about the need for training in addressing quality of life, that I think doctors do not think about this much. And then obviously the need for education of the general public. Generally, experience of care in the emergency unit was really appreciated, especially that patients received care quite fast. And generally, the experiences of care in the OPD and club was not as positive for patients and caregivers, describing a lot of disengaged care, re-scripting of medication, not necessarily talking to patients or examining them. One patient saying, I'm sometimes not satisfied, sometimes they don't even ask you if you're sick. But then a professional, interestingly, noting that in the OPD situation, patients tend not to raise their needs. So possibly something to look into. Experiences of care in the hospital, generally well received, and hospital care appreciated. But one caregiver saying, but once you're discharged, and there's no follow-up. Really highlighting, which professionals also highlighted, the need for care in the community. And in terms of discussions around prognosis and advanced illness, this seemed to happen more in the hospital than in any other setting, and probably because these were more advanced disease patients. Access to medication was very important for patients, and they struggled when there was stock or supply problems, but patients also reported running out of their inhalers quite regularly, and this causes worry and the various means that patients use to overcome this, sometimes buying medication, sometimes borrowing inhalers. And then also an issue raised was that when inhalers are changed, so if it looks different, the packaging different, whatever it is, a mistrust and what may be pharmacologically true is that there may be different activity of different drugs. So really, if one looks at an overview of the qualitative findings, communication is recognized as being important but challenging. And patients and families describe challenges in all the domains: physical, psychosocial, spiritual domains impacting quality of life. And that generally the experience of the healthcare system is broad, it's varied, but it highlights some policy issues, resource challenges, and a need for a person-centered approach amongst other things. So in conclusion, we can see that there are real diagnostic challenges for patients with COPD, and we can also see that there's a high prevalence of burden of physical and psychological symptoms, and this indicates evidence for a need for integrating palliative care into a primary care setting. Depression is prevalent, and we need to be aware of that and screen for that. And just to note that the physical and psychological symptom burden is not dissimilar to that's published in high-income countries. Another important thing to take home is patients and caregivers would like more advice and help to plan for the future. And just generally, there are many practical challenges in many levels in different ways. But it does seem that integrating a palliative care approach for these patients is important. So just a little look at the way forward. The overall aim is to develop an integrated intervention. And so SH2 is doing that, and we should have done that last year, but obviously COVID intervened. And so we're just waiting for final permission from the Department of Health to go ahead to restart with this trial, which is really a training and mentoring intervention, and assessing for the feasibility, but also assessing for potential outcomes. And it really is a feasibility trial, so it's a start. And I think really what I want to say is that there are obviously challenges, but I think it's exciting because there's a potential for collaboration and working together in terms of looking for solutions for the way forward for this particular group of patients and their families who are in the receiving care in primary healthcare setting. So thank you for listening, and I'm really happy to chat through any comments or questions.
Thank you very much, Lindsay. This was a very important conversation that you started here, and I think especially about how it relates to non-communicable disease care, specifically COPD, in a primary care setting, and the role of palliative care in that setting and how one can better integrate that. I think, like you said, the study has unmasked so much. I mean, maybe we are already aware of a lot of these deficiencies, but I think it's important to document and describe the situation that our patients and their family members are experiencing. And I thank you also for highlighting the next step of the ASSET project, which I believe is your PhD project, is how to develop such an intervention in a very collaborative way. I know that I'm not able to see registrars who maybe have their hands up in the seminar room downstairs. But you also, of course, it would be great to hear how some of this resonates with your own thinking, and maybe, yeah, just if there's any questions. Thank you so much. I see there's quite a few people in the room virtually, and we're having a bit of a blended format today with people also attending in person downstairs. Yes, Julian, please go ahead.
Hi everybody. Thank you very much for a fantastic presentation. And I think, you know, it highlights to us the massive burden of disease and suffering that there is out there. And I think that the palliative care service is very well positioned to move into that space. What I suppose what I'm asking is, there's so much work to be done, and there's so much that can be done that will ultimately save the health system an awful lot of money. Yet the project and palliative care on the whole doesn't have funding. So yeah, I was just wondering how can it be implemented with respect to, you know, the constraints of funding. Yeah.
Thank you, Julian.
Thanks, Julian. Yeah, it's a really important question, and I don't know that there's a single answer, obviously. I think, so I've been reflecting on this recently, and I think, so a palliative service is really useful, but I think in our setting and in terms of our resource constraints, we will be missing so many people if we just rely on a palliative care service. And so that's really the idea behind this idea of integration, integrating an approach at a primary healthcare level so that patients are supported early enough along the journey by their primary healthcare team, and that happens as integral to their care. And that's not necessarily been the case, and it's not necessarily been the training of healthcare professionals. And so that's recognized in the national policy that really we need to train. And so our intervention really is a training and mentoring intervention, because it's a mind shift, a paradigm shift. And I think in terms of the resource constraints, we do need to look at integration and the question of whose job is that anyway? Is it really only the job of the palliative care specialist, or is it just our job to care? I think it's a challenging one, and I think we need innovation and innovative ways to go forward, and a policy structure and a system in place that can support it across the board, including in the community. And task shifting is another issue that will assist here, but that requires support and a team.
Yeah. Because it was quite interesting that you said 90% of the, especially for the quantitative group, had family support, but they experience in terms of having just have someone to talk to and to just to bounce off ideas and issues, and getting that psychosocial support. And I also like the way that someone was about the short and the long version of the story. How we talk, and just like you say, some of the things should actually be just part of normal day-to-day quality care. I mean, the question that Julian also raised, and I see also Feroza mentioning it in the chat about the socioeconomic and financial impact that COPD has on a patient and family, makes one also wonder whether in terms of how one would approach this value for care assessment. I know from Renee that there was some from the health economics colleagues, there were people looking at the value for money for care in a tertiary setting. But I think the primary care context is in a way unexplored in that way. And I mean, earlier we were talking about the policy framework that should guide us. Yes, I mean, we have the National Palliative Care Policy, but even more internationally, we have the updated Astana Declaration with the focus on primary healthcare with palliative care as one of its foundations, together with health promotion and prevention and the curative focus. So I'm just also thinking about how can one realize our mandate to deliver the full spectrum of primary health care. And maybe, like you say, COPD patients is a very tangible niche focus group on how to develop that integrated and collaborative interventions that one could do. And I think that the lessons learned there will be able to replicate to patients living with other chronic conditions.
Yeah, absolutely, definitely. And I think so. There is some work done in South Africa on the cost effectiveness of palliative care, and we know that it is beneficial. So part of asset phase 2, we are also going to be looking at the indirect cost to the patient, and therefore looking at some degree of costing, so that so hopefully we will have some clearer answers on that. With asset 2, but it is important, and I think we do need to think laterally in terms of this, because it's also sometimes the chicken and the egg, what came first. We know there's social and financial hardship in communities, but the illness itself worsens that. So thinking that through holistically is important.
I think Julian has also added a follow-up questions. Why do you think so few patients are referred to physiotherapy? And maybe that also speaks to another level of integration of interprofessional care and practice. Is it just an access issue, or is there more to it?
So some professionals talked anecdotally about the fact that they used to refer a lot to the physiotherapists, but for some reason that had stopped. So whether it's just a practice issue or a practical matter, or the resource, the physios are not in all facilities are there physios that are full-time, so that's also a limitation. So maybe it's not in the guidelines, maybe we just don't think about it, but certainly the physios that are there, and one in particular I can think of saying, well, there is a lot we can do. But so being part of the team and the interdisciplinary team is a model that would facilitate that. Sure.
Wonderful. I just want to check in with the family medicine registrars in the seminar room. Simpiwe, are there any questions from your side? Simpiwe is typing. Okay, great. There's so much to take forward. I mean, I think you've gave us quite an in-depth situational analysis of the scope of the burden, and especially what I think is valuable also not only from the patient but also from the carer's perspective. And I think that really highlights the extent of maybe also how one can really think beyond the facility about what could be happening at the community level. Is that something you also involving in terms of your integrated strategy going forward?
Definitely. I think that the community is key, and the community care workers would, I think, be key. So the aim is that we will incorporate community, the people who train the community care workers, if not actually the community care workers themselves, and train them so that they can take that to the care workers, because I think that is key in terms of supporting patients in the community.
Absolutely, and I think that also speaks to the task shifting you mentioned earlier, about. I mean, on the one hand, I think that there's the burden of service delivery on the healthcare workers, but knowing that there is these very low cost, high value interventions that we can actually do that doesn't cost an arm or leg. It's just a way of maybe rethinking in how we organize the service to the patients, and maybe just move beyond the psychological barrier of the facility to think that actually there's something that can be happening outside in the community with NGOs and other partners.
Absolutely, and empowering those individuals to continue the care into the community, so that there's a network and available, and a link between the community and the healthcare facility. And I think it's happening with the multidisciplinary team meetings that are happening. I think it's a great, exciting place to start, and I think that's definitely what we would, build on. Don't want to reinvent any wheel, just build on systems that are in place and build on them.
Wonderful. I'm not seeing any more questions in the chat. Maybe a final word or a pearl from your side, Lindsay, about maybe how this initial project spoke to you, and what motivates you to take it further as your own doctoral project?
Yeah, so I think, the need that, Julian, you highlighted that need, the need of patients. It really, seeing the figures and the quotes in black and white just shows the need, and that is a motivation for me. One doesn't want to keep palliative care in a silo. Yeah. We need to get the care to the people who need it, and we need to do it in the best possible way that's feasible and acceptable to everybody, and cost effective for the system and health system strengthening as a best result. Yeah, so that's the motivation.
I can imagine, and that will help you feel your passion to take this project through and to fruition. Yeah. And we wish you every success to that, and looking forward to learning more from your experience and the research that you're doing.
Thank you, Klaus. It's been great to share. So thanks for the opportunity.
No, thank you, and thank you for also to you and everyone who's attended here today. So obviously, I think if people are keen to ask you questions directly, they're probably welcome to contact you.
Yeah, absolutely.
Yeah.
Super.
Well done.
Thank you.
Thank you so much. Thank you very much, everyone.
Thanks, everybody.
Go well. Speak soon.